Okay, so this evening, Dr. Mike and I, we'd like to introduce Dr. David Platt. Dr. Platt has been researching hypoxia and galectins for over 30 years. He is probably one of the world's top experts in this field. He's got 30 patents, 10 journal articles, 2 textbooks, ran 5 public companies, 200 animal experiments, and close to 30 clinical trials. And I just want to, on behalf of Dr. Mike, I'd like to first thank you, Dr. Platt, for joining us tonight and sharing with us your expertise and research with not only with us, but the rest of our social media community. So thank you, Dr. Platt.
Thank you for having me.
So I just want to start out with, a few weeks ago, I sort of dropped the whole concept of galectins, and that obviously opened up a whole new, maybe a can of worms, if you want to say, or a whole new world, depending on how your perspective is. And then you and I sort of had a couple of conversations. Could you just start out by maybe talking a little bit, what are galectins? Why were you interested? What was your inspiration? And also a little bit about your sort of your education and research background into this field. Why was it important to you and a source of inspiration?
It was in the 80s, and I did my PhD on carbohydrate chemistry. My background, I'm a chemical engineer, I'm an organic chemist, and I specialized in carbohydrate chemistry. And I was very interested in a new field in the early 80s, which was completely new in the beginning of the 80s, that carbohydrate play a role in biology. That was totally new, and in the late 70s and early 80s, it was discovered by my mentor, who dead by now, rest in peace, and Nathan Sharon, and that guy, Professor Nathan Sharon, with other people, discovered and worked on a group of protein called lectins, Lectins. S is many lectins. And they discovered that there are specific receptors that are recognize only carbohydrate. I said, wow, this is interesting. Let's do a PhD. That's my PhD. It's on chemistry of carbohydrate. And let's see if I can manipulate those carbohydrates. And the first thing that came to mind is what kind of manipulation. You can go with a single sugar manipulation, or you can go with a several sugar manipulation. I'll give you an example of the complexity. Did you understand the magnitude of the complexity? 4 amino acids, when you take 4 amino acids and you put them together, you will get about 254 combinations. But if you put 4 sugars together, the numbers are staggering. The number is 30,000. 4 sugars. So I decided to work with molecules that are greater than, and I know that it sounds absolutely insane, but I'm talking about molecules that contain between 700 and 1,000 sugars. It's impossible to synthesize them today. There's no science to synthesize that large amount of sugars, because the combination in synthesis will go to trillions and trillions and trillions by the trillions of combinations. So you need to be very precise. But what I was fascinated from the fact, in nature, the sugars are the fine-tuning mechanism of recognition. So that's my background. I did my PhD in carbohydrate chemistry of how to manipulate sugar in the cell wall from plants. Plants knows how to manipulate sugars and keep them in the same structure. We don't know how to do it. We know a little bit in proteins, but we make amino acid. We know how to build DNA or RNA. We have no clue how to synthesize sugars. I think the maximum that people synthesize today properly, it's maybe 6 or 7 sugars. Think about this. That's it. So it's an unknown, it's the holy grail of recognition is carbohydrate. And then after that, over the years, people discovered the role of carbohydrate in what you call glycomics, how sugars are important for dissociation, for structure, for keeping the molecule in what you call glycoprotein. And even today, the roles of sugar is in many proteins is unknown. And you know that if you don't have the glycosylation on the molecule, which is the fine-tuning of the structure in the manufacturing by the ribosome, you will not get the right protein. So that's my background. So I'm a PhD in carbohydrate chemistry, and how I got to biology and into cancer, it's a story by itself. When I did my PhD, I realized my postdoc in Michigan, and by Wayne State and University of Michigan, I discovered that I can actually manipulate the sugars in certain way. And then I found that when I separate on cancer cells in 3D, gel, which you do a 3-dimensional gel, I was running and I found out through testing, I figured out that it recognized, I have some receptor that recognize sugar only. And I realized, okay, there's lectins on we're talking about early days of this way of thinking. And now it's very interesting. I came to the conclusion that, wow, if we have cancer, what actually make the cancer cell to become metastasis? So I said to myself, that was my postdoc, maybe I can create a. First, I learned that type of receptors, I separate them, and then I decided to clone that receptor. So I successfully, in those days, you must imagine that it's extremely difficult, and many nights I didn't sleep. And eventually I was successful to express the receptor for galectin-3. I call it galectin because I call it galactose binding lectin. That's why I call it galectin. That's a name that I put together in my publication in 1993. And I also published the 3-dimensional structure of that receptor by expressing that, so I have enough of it, so I can do it on the electron microscopy and the NMR. And then the idea was to understand if that's such an interesting receptor, what I should do with that. I mean, it's another receptor. And to my surprise, by the way, I'm boring you or something? You look like you're sleeping there. It's okay?
Yeah, no, you're doing great.
Okay. So what I find out, to my surprise, that galectin, first of all, I discovered that there are few galectin, not one, and when I express them, I find out something very interesting. All of them recognize the sugar galactose, beta galactose. So the question was why galectin galectin, which I call it galectin at that time. It was CD34, that was the original name, but I call it galectin. So why galectin recognize only galactose? And my thinking was it's very conservative. It's a very conservative receptor. So if it maybe has a role in many process of infection or in recognition. So I decided to design a sugar to block the receptor, block metastasis.
Dr. Platt, I just want to, because this whole concept of galectins, it's a very new concept for a lot of people. So just to recap real quick, and correct me if I'm wrong, it's a protein that recognizes carbohydrates. And
absolutely, yes.
Okay. So what you're saying is that there are a lot of processes in the body, like the immune system, where it's modulated by where galectin is playing a role in sort of the immune system fighting viruses, causing an increasing cytokine storms, viruses, cancers. Am I correct? If we could sum it up.
Yes. What surprised me after 35 years that I'm doing this, there are many scientists who don't understand that carbohydrates play a major role in immunology, in recognition, and cell-cell interaction, in bacteria, viruses, and cancer metastasis, and other immune system modulation. It's incredible that people publish articles ignoring completely a carbohydrate recognition. It doesn't exist for them. Scientists don't know about it.
We had initially talked a couple of weeks ago about how when it comes particularly to COVID-19 and even influenza, some of the other viruses, that it was a carbohydrate recognition virus. Can you talk a little bit about how some of these viruses, like what does it mean when you refer to it as a carbohydrate recognition virus, and how is that important? Let's say as clinicians like Dr. Mike and I, if we're treating or trying to approach, let's say, a virus like that, in your opinion, what would be the best approach to those carbohydrate recognition viruses?
By the way, I'm not the only one who talk about that. There are several scientists. To answer your question, I can refer to one person that I particularly appreciate. His name is Gabriel Rabinovich. He wrote a major review on carbohydrate and galectin recognition and carbohydrate. Okay, so I will tell you later a story about my interaction with Dr. Rabinovich. But to answer your question, I look on viruses and cancer cells and bacteria and any recognition as the first event of recognition. It's a carbohydrate recognition. It can be three ways of recognition. The lectin is on the human cell, and it's carbohydrate on the virus, in this case. It can be a carbohydrate on the human cell, and the receptor will recognize the carbohydrate on the virus. And it can be, to many people's surprise, a carbohydrate recognition. Carbohydrate recognize other carbohydrates. They act as a magnet to each other. So those three possibilities can be approached from a developing drug or drug development perspective. Remember, I'm a drug designer and I'm a drug developer. So that's what I do all my professional life. So what it is, how you tackle that situation. Right now, it can be a small molecule. It's a problem with small molecule because it gets secreted by the kidney very quickly. So the half-life is really miserable. It's very small or short. Another way is to do antibodies. antibodies has a problem for different reasons, and I can get into it from a structural perspective. The arms of the carbohydrate, the distance, does not allow you properly to block it. And there is a way, and the ultimate way to protect or to block that which I had recognized 30 years ago, which I did, by the way, and I'll tell you about cancer metastasis, how we block cancer metastasis and shrink tumors by injecting only carbohydrate. So you can have a drug that is made of carbohydrate only, which is, by the way, non-toxic, which I tested in human, and it works fantastically to block completely cancer metastases and shrink tumors, based on that mechanism of blocking specific receptor. In this case, it's galectin receptor. So the idea of virus recognition through carbohydrate, it's essential. And today, in all the modalities that people using to prevent virus infection, the carbohydrate inhibition is not there.
So your point is that these viruses, for example, COVID-19 situation we're in right now in this pandemic, it's looking for other sugar receptors or carbohydrate receptors, or looking for that's the attraction.
Yes, because that's the attraction, because in this case, the galectin receptor, which was hijacked by the virus, I mean, in terms of evolution, it hijacked why the virus, the COVID-19, hijacked the galectin-1 from the human tissue, from the human cell or the gene. And the reason for that it need to recognize the antenna, and the antenna is the carbohydrate that sticks from the human cell. So if the virus goes by in the bloodstream and recognize the antenna, which is the sugar, the galectin on the virus will attach to it and will start the recognition of other receptors or other mechanisms. That's the first event in terms of molecular distance, will be a carbohydrate event. So how to prove it? For example, I can tell you in cancer, in clinical trial, by the way, I did it with MD Anderson, with the Chris Lugatitis in MD Anderson for prostate cancer. We completely inhibit metastasis by injecting carbohydrate. I did the same thing in colon cancer. And so the reason that the drug was not approved, because in those days, there was no validated method to measure cancer metastasis. Right now, we can do that. We can go into the detail and do the drug as an anti-cancer metastasis drug. And by doing that, we attach ourselves to all the cancer cells, treating with all the drugs, treating primary and secondary tumor, because we block the metastasis. The metastasis is what kills patients. It's not the primary or secondary or tertiary tumor. It's the metastasis who kill the cancer patient.
And that's interesting, because one of the things that has come up in studies now is the spike protein on COVID-19, going back to COVID-19, is covered by a glycan or sugar covering. And,
yes,
you and I have talked a little bit about, there's a lot of discussion about vaccine production. And there's some skepticism as if these vaccines are going to work. And we're seeing some, I think Moderna put out their mRNA vaccine, and there's been a lot of speculation about how valid those trials were, and some complications some patients have been complaining about. In your opinion, if we are developing a vaccine for COVID-19, should we be targeting that glycan or some sort of sugar receptor on the virus?
The answer is no.
And how would you approach? Do you have any ideas in terms of structurally what on the virus we would want?
if we're talking about vaccine, I don't have enough knowledge in terms of how to approach from a vaccine perspective, what are the genes or the envelope genes that are important for the vaccine creation. So that requires a different discussion. I can contribute if I have the interaction with vaccine developers, but it's a different subject that I cannot contribute that right now, okay? But I can contribute to the treatment, for example, because the problem with vaccine, it requires 20,000 people and an issue of toxicity and specificity. With what I'm talking about is a treatment that those patients that getting into difficult situation with the immune system activation can be treated theoretically or practically with a non-toxic sugar, which we propose to develop the same way we did in cancer. And that sugar will basically block the recognition between the virus and the human cell. And as you inject the sugar, the sugar will actually clear the virus from the system, allow the immune system to take control. Also, the immune system has the same receptor as the virus, so you actually quiet, or you lower what you call you will lower the cytokine storm. By the way, everything that I talk about already published by other other investigators. So it's not like it's there. By the way, just to remind you, there are I was the #1 article in Galectin. There are 4,000 publications, scientific publications in Galectin. How come the medical community ignore completely Galectin in COVID-19? This is a question that so we'll be, if we get the enough funding, we'll be the first one to demonstrate that. I challenge anyone who is in the field, go and test it on patients, okay? So that's #1, whatever you have. I don't know what they have, but some of them, by the way, some of them, it's my previous development. It's not the right molecule, but at least you can have some results. My point is that to have a 100% reduction of the virus simply by recognizing the galectin on the corona and let the immune system, and at the same time, since the same receptor exists on the immune system, quiet the immune system, which is upregulating the same galectin receptor, and by doing that, allow the immune system to take care about whatever left from the virus, because over time, you just reduce the viral load like in AIDS drug, and you get the patient to take the immune system take care about it.
Dr. Platt, I want to ask, what research has been published that has shown that inhibiting these galectins can inhibit viruses? Has it been shown to inhibit virus such as influenza, MERS, the first SARS virus, rhinovirus, other coronaviruses? And if so, what animal studies were they?
Yeah, there's to your surprise, I'm going to surprise you. There is a publication from 2011 that showed that by blocking the galectin-1 in influenza, which galectin-1 is what has on the coronavirus, has the same galectin, block and cure rats, cure them, 100% cure. It published 9 years ago.
Can you tell us what journal that was published in?
I don't remember, but if you punch
Google Galectin 3 and influenza and rats.
Galectin-1.
Sorry, Galectin-1.
Galectin-1 influenza and in 2011, I believe that's the year. I don't remember. I'm reading too much, so I don't remember. sometimes I'm not sure that I know how, if I know how to read, so much data, you need to be, it's too much. But that's a very strong evidence of the complete inhibition in animals of galectin receptor to show clinical benefit for animals, completely pushed aside in terms of the direction. So I'm very excited about that I can contribute to viruses, so to speak. By the way, Dr. Rabinovich, he has a review from last year, and he described there are about 15. Okay, let's go back and understand what happened here. There are about 15 galectins known today. Now listen to this. All of them recognize the same beta-galactose, which was, remember, it fascinated me in the 80s. So that's the reason why I was concentrating on expressing the gene and understanding the structure. So I will tell you a story how I discovered the sugar and how I figure it out that it's only recognized galactose. So what I did, I took 3 cancer cells, okay, and I put them in a petri dish, and on the petri dish, I spread gold particles. So you say, why gold particles? Because with the lamp, if you go from the side, simply the gold particles shine on the petri dish, and it gives you kind of a red dot, a black dot if you take a picture. And now you let the cancer cell grow, 3 cancer cells, 4 cancer cells that can divide to maybe 6 cancer cells, 3 cancer cells to 6 cancer cells. As they divide, the cancer cells move. They have a motility capability. Remember, those are cancer cells that are metastasized. They have the ability to move because they have a motility factor. It's another receptor which is called GPS 78, I believe. But they move and they clear the gold particles. Now, what is the trick? You block the receptor with an antibody, and then, but the cell is still moving because of the galectin. And then I start and dropping all kinds of sugars on it. Remember, there are about, I would say, more or less 30 sugars that are in biology, known to biology in human tissue, including glucose, galactose, mannose, and xylose, and other sugars. I don't want to get into it because there are sugars which are charged and non-charged. So I find out that every time I throw in galactose, I block the motility of the cancer cells. I was very happy. That's how I discovered the beta-galactose role in galectin. So answer your question, why I told you that story, because there are 15 galectins in all viruses. So if galectin 1 and 3 exist in influenza, in AIDS, HIV, and in COVID-19. But other galectin exist in other viruses. So I assume if I would design another sugar to galectin 4, galectin 5, galectin 6, galectin 7, galectin 9, I don't remember who has what, but each virus has its own galectin, and they are in an order to recognize only carbohydrate on the human cell and vice versa.
So Dr. Platt, I think a lot of people wanting to know in the comment section, in the question section, is what is the next step in order to get the drug that inhibits the galectin 1, the galectin 3, what is the next step to get that into clinical trials in humans?
I just need to manufacture that. in a couple of months, because it was already by the FDA, a review by the FDA. I just need to manufacture it properly in another month or two, and it takes a very short period of time. I'm working on that for 30 years on manufacturing. For me, it's really not a big deal, and I do some animal testing, validate the structure, and I have a collaborator on doing what I do. You need to validate the structure. You need a complex, but I work on that. I published in 2009 the structural analysis of the key and lock. I mean, the sugar, how it recognized the galectin. It published a very precise chemistry. We're talking about 750 sugars. It is well designed, consistent. We can make a lot of material from that. We inject it to patients, COVID-19. We show that we will lower the viral load, and the rest is history. We have a non-toxic IV drug to eliminate COVID-19, a treatment. That's the idea. The same way we did in cancer metastasis.
So, Dr. Platt, can you talk a little bit about, you have developed this drug, I think it's BXT25 and 10. Can you talk a little bit about that, its role in COVID-19, I think in other viral infections, and also for something, Dr. Mike and I, we encounter in our practice is pulmonary fibrosis. And in post-COVID-19 patients, this is something I've been sort of researching and talking to a lot of people. Post-COVID-19, there's now a lot of cases of pulmonary fibrosis. This was seen in the first SARS infection outbreak in 2003. When they did post-infection CAT scans, they noticed significant fibrosis in patients that recovered. We're starting to see that now. So you've developed this drug, which in my understanding can not only treat an active COVID-19 infection, which, and if you can talk about that, and also talk about the role in fibrosis, because clinically, those are two really big things that we don't have right now, that if we had that drug at disposal, we can not only save lives, but also improve the quality of lives of many of the patients recovering.
Absolutely. So in 2005 and 2006, we published a review, and we presented in a conference with Scott Friedman in Mount Sinai that we reverse fibrosis, liver fibrosis in animals. And it was unnoticed. Again, this is a drug made of carbohydrate only, a complex carbohydrate. You inject it, and but the beauty about this idea, which I discovered, was that galectin-3, in this case, is involved in fibrosis, and by blocking the galectin-3, we were able to reverse fibrosis, not just block the fibrosis, but reverse the fibrosis. So if we design in that one of the drugs we give the COVID-19 patients, if we give them the inhibitor and the antagonist to the galectin-3, it will affect, I assume, very strongly. By the way, I'm not the only one. It's published by other people that if you reverse galectin-3 in fibrosis, liver, we're talking about pulmonary fibrosis, you will block the process of fibrosis and reverse it the same way. So this is one of the things that we can do for those patients post-COVID-19 treatment.
So one of the things that, when I was looking over your presentation, which, by the way, Dr. Mike and I will post a link to your company, BioXTRAN, and all the research that you're doing, which is pretty groundbreaking stuff. Now, something we talked about was hypoxia. It's when you have low oxygen. It triggers the expression of galectin 1 and 3 in the body. And by blocking the galectin 1 and 3, the idea is that you're eliminating the mechanism of fibrosis and potentially the fibrotic tissue becoming fibrotic.
Yeah. You
Okay.
see, I decided I wanted to attack it from two directions. One is the one direction. I decided to go and with a holistic approach to attack the hypoxia situation from fibrosis. What I said, I'm saying to myself, you need to understand, I'm talking to myself here. I'm the only one. So I'm talking to between this, I'm talking to myself.
We all do it. It's okay.
Sad. What? Say it again?
We all do it. It's okay.
Yeah. So I said to myself, I'm talking about 15 years ago, 20 years ago, and what should I do to go from hypoxia situation and from the expression of the most important member of keeping the fibrotic tissue. So I find out that there is a way that I can actually attack the problem from two directions. One, I can block the galectin 3, which participate in fibrosis, and I don't want to enter to all the mechanism that goes in there, but it's a key member that already proven in human that you can block fibrosis. And second, which I said I'm going to do, I took hemoglobin and I stripped the hemoglobin. Now it's a little bit unorthodox, and I'm probably the only one who did it. I stripped the hemoglobin from the globin, and I took the heme, which is that's the carrier for oxygen, and I stick it on a polysaccharide. So now I have a polysaccharide heme. Okay. Now I have an oxygenated molecule. And that molecule, similar molecule, was tested and showed that it carries oxygen very nicely. We did in Harvard Medical School some testing about nitric oxide scavenging. It just connects only to oxygen. It releases only oxygen. And we kept, and it's a very conservative structure. So it's non-toxic for human. And we want to take it into human trial as a oxygenation material. Now, why it's important? Because in fibrosis, the cell or the pipes that carry the red blood cells to the fibrotic tissue are mingled, are destroyed. So the red blood cells cannot penetrate those pipes, so to speak, the capillary, are too big. So that molecule, since it's about 5 to 6 micron, can go through and deliver and release the oxygen. So it's a molecule that you inject IV. We wanted to use it also in stroke that can penetrate the clot and deliver the oxygen and goes back to the lung and also deliver the oxygen, release the oxygen. On top of that, the question was how are you going to approve it? So we developed an FDA-approved device to measure the oxygen in the tissue, approved by the FDA. It's a new, completely novel mechanism of detection, because in that mechanism, we detect the mitochondria. No one today is detecting oxygen by the mitochondria in the tissue. So we have the most sensitive FDA-approved methodology and device. It was never commercialized, but it can be test the tissue, the fibrotic tissue, and test for the. By the way, the device was approved for ARDS patients, so we can use it in COVID-19 patients. It gives the physician well in advance, like a smoke detector, the ability to detect oxygen, but in the same time, we have the drug. A potential drug to inject and deliver the oxygen and treat the galectin 3 and block the mechanism from the other side when there's a gene express that receptor, which a cascade of mechanism to keep the fibrotic tissue and remove that inhibition from the fibrotic tissue to put it back to normal. So I have those three ideas trying to develop them.
And in terms of the cost, you said that's FDA approved. Could we get it in our hospitals right now? The
device?
Factor, yeah.
The device, it's about to take about $2 million to get it into testing, not testing, into commercialization, if we want to do it. We want to do it, but we didn't find the right company because the market is controlled by companies who are measuring the amount of oxygen in the arteries, not in the deep tissue. So it's, from my perspective, it's not the right way to do it because no one actually measuring mitochondria and deep tissue oxygenation.
And real quick, Dr. Can you talk a little bit about your company, BIOXTRAN, just to give us a little brief background, because obviously you've done some exciting research with these galectin inhibitors and developing a device for hypoxia. Can you just give us a little background into your company?
The company is a new company. We took an existing company and we just the original company, people were simply retired. So he's a friend of mine, and we took the company over, and the idea is to fund the research and to do the clinical trial. It's a regular small biotech startup but in this case it's public. We find out that I found over the years that raising money, it's much easier, or at least it's easier than dealing with venture capitalists. It's more like established fund who recognize, or investors who are they call smart money. They understand better the company and they help you as you progress to fund the company.
Dr. Mike, do you have any questions? Things you'd like to follow up with Dr. Platt?
Nope, no more questions. I appreciate you coming on here, Dr. Platt, and telling us about the galectins, and you obviously have the most knowledge in the world about them, so we appreciate you coming on here and talking about that.
Do our audience have questions for Dr. Platt about galectins, carbohydrates? Dr. Platt, one of the questions we had gotten was we were saying you were going to come on and have a chat and discuss your research with us. Was a question we got was, do carbohydrates from the foods we eat, does that have an impact on galectin?
Not whatsoever.
And
it's nothing to do with we consume glucose. That's the only molecule that related to eating and converting to fat and energy. Other carbohydrates are generated by synthesis with our genes, or mostly by synthesis. And they take the human cell take carbohydrate from the environment, but it's really minute contribution. It's not really, this is not like using glucose in massive amounts every day. It's nothing to do with eating.
So why are some people more genetically predisposed to having more galectin? Because there's obviously some literature that states that people with diabetes, heart disease, atherosclerosis have high levels of galectin. Could there also be a genetic component? The reason I ask is in COVID-19, we're seeing, I believe, the real pathogenesis, the real cause of mortality is cytokine storms. We've established that galectins play a role in increasing or even encouraging, or whatever you want to call it, the cytokine storm. So is there a certain subset of people that are genetically more predisposed to making more galectin, hence more cytokine storms? What is your opinion on that? Do you have any insight to that?
without getting into the details of the immune system, just in a very simple sentence, activating of the immune system, of the members of the immune system, involve upregulating of galectin receptor. And especially galectin 1, galectin 3, there are different galectins. So why, by the way, why the galectin? Remember that my questions for 35 years ago, why beta-galactose? And how come that beta-galactose, the same sugar, the receptor, there are different receptors to recognize the same sugar? What it means? So the answer to your question is the fine-tuning of recognition by the immune system that is upregulated when you have an activation. For example, I'll give you an example in T-cells. T-cells, there's a very important experiment. No, I'll tell you a story. To answer that question in a very nice way, I'll tell you a story. Merck created a drug named Keytruda, right? Non-drug, for anti-cancer drug. Now listen to this. 40% of the patients, if their galectin is upregulated, it blocks the ability of the T cells. It actually covers the T cells which have upregulated galectin 3. So it blocks the ability of the Keytruda to kill the cancer cells. And that's the answer to your question. What is the value? What happened with galectin? The upregulation is definitely associated with blocking the immune system from recognizing cancer cells, for example.
So if you were using a galectin blocker, if I had a COVID-19 patient, your galectin blocker would form a complex, and my understanding is it would then get excreted by the liver or as an inactivated complex. Can you talk a little bit about how that works and how long, let's say I have an active COVID patient in the ICU. If I were to give your galectin blocker, BX25.
You can, since it's non-toxic, it's already tested in humans. So you can give the patient for 24 hours or 12 hours, and it will slowly, or not slowly, very quickly actually, reduce the viral load and clear since the sugar are usually cleared by the liver, so it will get cleared by the liver, and the virus will be cleared by the liver. It will be attached every time there is a bunch of virus in the pipe, so to speak. It will be cleared by the sugar. The sugar will be attached to the virus, will be cleared.
And so, I mean, one approach to treatment of COVID-19 would then, instead of an antiviral like hydroxychloroquine or remdesivir, we could give BXT25 and possibly a monoclonal antibody on top of that, like leronlimab or tocilizumab or some of the other drugs. That might probably be the most effective. From what you're saying, it actually might be better than an antiviral, because this is you're going to decrease your viral loads within 12 to 24 hours.
Yeah. That's the idea, is to clear the viral load in 24 or 12 hours. I would say 12 hours. In cancer metastasis, we saw it in few hours. So we're not talking about days, we're talking about hours. And you add to another drug, which is a polymerase inhibitor, or any other, I call it Trojan horse. The method of what people are using today. Whatever they're using today, there's no silver bullet to any treatment. I mean, silver bullet doesn't exist. But it's a major thing. You will reduce the viral load, you have the immune system, and you quiet the immune system. Remember the galectin 1, galectin 3 on the immune cells, on T cells. We remove that one, so we have the better T cells activation. Remember that story with Keytruda with Merck, that you can increase the value of Keytruda by removing the galectin-3 plaque on the T cells. So now the T cells works better. So now you will remove the galectin-3 from the T cells, which is like a cap, to block their activity. The T cells work better. You give another antiviral drug, whatever it is. If it works maybe 40% or 20%, now it becomes 100% because you reduce the viral load. Things like that, a combination therapy. But first our goal as a company, as a small company, is to do proof of concept. And now you do a proof of concept, you go to a large pharma and you do a collaboration and you show it with other drugs. That's the idea.
So in terms of a timeline development, how long are you looking at?
If we have the right money, we can do it in months. It's not a long time. Remember, I have many years of experience of manufacturing the carbohydrate properly. This is a story of, it took me about 10 years to understand how to manufacture and control the structure. You need to manufacture the same structure. It's a drug. So you need to show in 750 sugars to 800 sugars, it is the same structure. It requires an accelerator. This is not DNA or nucleotide. Running a gel would cost 2 cents. It's more sophisticated that we need an accelerator to measure molecular weight. Sugar are a completely different language in chemistry. Most of the scientists are totally clueless. It's like learning Chinese and you speak English.
Well, so, thank you, Dr. Platt, very much for...
Within chemistry, carbohydrate chemistry, it's a language by itself. That's my thing.
Thank you very much, Dr. Platt. Appreciate you coming on. Our time is running short with you. We have to save some time to answer questions for our guests tonight. So okay. We do appreciate you coming on here. Thank you once again.
I have a Dr. Platt. Someone was asked for Dr. Platt. The question was, highly conserved lectins may hold clue how to lock down COVID-19. Oh wait, here's the question. Is it true that only 50 sugars exist in virus?
The communication, I got lost a little bit. I don't hear the...
It's true that 50 sugars exist in virus.
You cut off. You're breaking up.
Ms. Dr. Platt, is it true that only 15 sugars exist in viruses?
It's 15 galectin. Discovered 15 galectins. Only 15 galectins were discovered, but all of them recognize one single sugar. All of them. And those 15 galectins exist in different viruses.
Do you have any questions for Dr. Platt from your guest, from your people on your channel, Dr. Mike?
Nope.
Okay, one last time, any questions for Dr. Platt tonight? If you don't have any questions, then Dr. Platt, thank you so much for coming on with us. Galectins are very interesting. I think a lot of people don't appreciate the role of galectins. Your research is very impressive. It needs to be heard by a lot more people. I think, obviously with a novel coronavirus and this outbreak, we're still trying to get a better understanding. And if galectins can play a key role in COVID-19, it can unlock so many other things that are a conundrum to a lot of clinicians like myself and Dr. Mike. So we'll be really interested to see how your research comes along. I know Dr. Mike and I will post a link to your website, BIOXTRAN, in the description section, comment section of the video, and on our social media. So if people want to get in touch with you, we'll also put your email address if people have more questions that they can reach out to.
Very good. Thank you for having me.
Thank you, Dr. Platt.
All right. Good night.
Good night.
Okay, from our audience, any questions for Dr. Yo or myself? Doesn't have to be Galectin related, it could be COVID related.
Think you have any questions, Mike?
Yeah, you're kind of cutting out. Is your microphone okay?
Yeah, I might have to put my headphones on.
Oh, okay.
Is this better?
Yeah, that's better. Do you think that cases in states reopening are going up? That was one of the questions. What do you think about that?
What's that? Say that again, Mike.
One of the questions was, do you think that the states that are reopening, do you see the numbers going up moving forward?
You know, this is a tough question, because the reality of it is we're not ever going to get down to zero with COVID-19. So we have to be realistic about it, and we have to balance keeping the economy and the country open at the same time maintaining social distancing and wearing masks. So it's a fine line. People are losing their jobs, losing their minds, literally. The number of depression and anxiety in the country have increased over the past several weeks and months. So you're starting to see increases in the states that are opening up. It shouldn't surprise us. But hopefully we can have a vaccine and medications which are going to prove effective. Unfortunately, we're starting to see some evidence that Remdesivir is not as effective as we had hoped for. And this is why some physicians and researchers like myself have high hopes for leronlimab and that it'll be approved, because even though the numbers are coming down, it's going to be here for a while, and we need to have some effective treatment.
Now, I know you just made a video about your favorite topic in the world, vitamin D. And I just made a video about vitamin D that wasn't necessarily about vitamin D with respect to COVID. Now, I actually haven't posted it yet, but tomorrow I'll be posting a video about vitamin D and its relationship with COVID. There haven't been any randomized controlled trials so far that have looked at vitamin D for COVID. I just checked today, and as of right now, there are 3 randomized controlled trials that are looking at vitamin D, or will be soon. They're actually enrolling patients in the study now. What is your take on the epidemiological data looking at these pockets or these demographics of the population who have vitamin D deficiency, and then comparing that to the demographics of the people who are most frequently dying of COVID, who have the risk factors such as high blood pressure, obesity, diabetes, older age? What are your thoughts on that?
You're asking me, Mike?
Yeah, because a lot of people want to know. A lot of people have been commenting on my last YouTube video and yours as well about vitamin D. So,
like vitamin D and the epidemiology?
Yeah, because to me it seems like there's a lot of overlap between the two demographics. I'm not saying everyone who has normal vitamin D levels, I'm not saying they can't get COVID or they can't get severe illness from COVID or they can't die from COVID, but it seems like the ones who are having more severe disease, based on what I'm seeing in the studies, most of them have lower vitamin D levels. So again, we don't know if it's just a correlation where they just happen to have the same risk factors, or is there something to that where vitamin D having deficiency is actually playing a role in having worsening disease? I mean, obviously, there's no way to know until we get, randomized controlled trials, but
there's a lot of different correlations, we can make. I think there was a study a couple of days ago said people with long fingers or long ring fingers, or I forget what finger it was, have less susceptibility for COVID-19. I mean, we can go down the list and make all these correlations. I haven't had COVID-19. That's because I sleep on my belly. I mean, we could say that, but it doesn't necessarily mean anything unless we have, like you said, the randomized control studies.
The other thing too that complicates matters is that there's essentially no harm in someone taking 1,000 IU's a day of vitamin D, right? And it's hard for people to actually get their levels checked right now because no one's really going to the doctor unless they have to.
Right. I think the other thing is there's no international consensus, and I talked about this in my last video about vitamin D. So when you don't have a consensus, at least with various health organizations, you're going to start seeing variations and discrepancies in what is suggested. The FDA has their recommended daily, not the FDA, the NIH has the RDA, which goes over the recommended daily allowances for vitamin D, which tends to be a little bit on the lower end of things. I think it's about 600 international units for adults and 800 international units for people over 70. But again, if you go to any vitamin store or a health supplement, I mean, you're going to see sometimes 10, 20, sometimes even 50,000 international units. Is it harmful? I mean, very unlikely someone's going to get vitamin D toxicity. Studies that suggest people taking 10,000 IU's daily for a good number of weeks and months develop toxicity, but there's really no consensus with that. But I don't really see any benefit in taking these high doses unless you are, let's say you are vitamin D deficient. Then, under the auspices and guidance of a physician, then, you should, I don't see any problem taking that because, like I said, you're under the guidance of a physician. But someone that is not deficient and thinking they're going to quote unquote boost their immune system, I don't see the benefit of that. And second of all, and I did mention about this in my video, was there's nothing called boosting the immune system. You boost the immune system, you're going to be in a cytokine storm. That's just really what it is. The key thing is we want to say balancing or optimizing our immune system. Taking vitamin D if it is not going to prevent an infection, it's more likely it's going to optimize your immune system. So when you are exposed to the infection, you have a balanced and optimized immune system that's ready to fight. We do know vitamin D plays a role in immune modulating, especially T cells, which I know you talked a little bit about it on your video too, Mike, about the vitamin D receptors on the immune cells. But I don't know if it plays a significant role in quelling the cytokine storm, if that is if that's what people are thinking by taking high doses of vitamin D.
Yeah, and again, just to, hit on that point, there are a lot of people in this world who have vitamin D deficiency. Certain pockets, we talked about the demographics, lots of areas in Europe, such as Switzerland, France. And actually, when you go north of those areas in Europe, such as Denmark, Norway, Sweden, they actually have higher levels there. There's actually very few people who have severe vitamin D deficiency in those regions. They have less vitamin D deficiency overall compared to France, compared to Switzerland. And it's probably because a couple of reasons: the fortification of their food, but also their diet. They're probably eating more fish there. So that's interesting. But in terms of, the harms of vitamin D, it really comes from an indirect effect when you raise calcium levels in the blood and you get too high of calcium levels. But in order to get too high of calcium levels, someone's really got to be taking big doses of vitamin D. Now, there are some studies that are suggesting that when you get to vitamin D levels higher than 32 mgs per ml, that can impair your sleep by inhibiting melatonin production in your pineal gland in your brain. So again, is impairing your sleep the worst thing in the world? No, but sleeping is pretty important for your overall health. And when you talk about what are the things that you can do to optimize your immune system, not boost it, but optimize it, it's sleep, reducing stress, exercising, healthy diet, avoiding the bad things, and possibly vitamin D.
Mike, real quick, can you guys hear me right now? Sorry, I muted myself because I'm hearing the water drops in the background, which are I think we got to sort this out. I'm picking up the messages from whenever you get messages. For some reason, it's resonating on my end, so I try to mute myself.
Okay, I'll
They
turn
couldn't
my
hear me.
volume down so maybe it's not as bad.
Can you guys hear me? Either give a thumbs up or say okay.
And while you're doing that, I just want to say thank you to Carla Honig, who says, thank you for sharing your medical intuition and wisdom. Well, thank you, Carla, for coming and participating.
Okay, I think these I think they can hear me now. I'm just going to quickly just repeat what I said. Basically, my point was about vitamin D, and I had said with Dr. Mike that I didn't see any benefit taking very high doses of vitamin D. If you are taking high doses, I mean, there is a place for it, and that's if you're vitamin D deficient and you're under the guidance and auspices of a clinician or physician. There is nothing to suggest that very high doses of vitamin D, if you have normal vitamin D levels, are going to quote unquote boost your immune system. There's nothing called boosting the immune system. That's just something supplemental and nutrition stores like to use and companies like to use as a marketing tool. If you boost your immune system, you're developing cytokine storms. That's really what the gist of it is. So the key thing to remember is balancing and optimizing your immune system. And by having normalized vitamin D levels, you have an optimized and balanced immune system that is ready to fight an infection. There's nothing that vitamin D prevents infection, whether it's with COVID-19 or any viral or bacterial infections. It just means you're ready to fight.
Well, in a way, it prevents infection if it's too low. So, I'm sorry, I worded that wrong. It will prevent. So, vitamin D will prevent infection as long as your levels are high enough. But getting them higher, it's like adding more water to the pool, or adding more water to the glass when the glass is already full. And in fact, when you do that, you start running into issues that you don't want, whether that be, impaired sleep or too much calcium. Sometimes there's some evidence suggesting that too much vitamin D can play a part in autoimmune disease, such as lupus, rheumatoid arthritis, psoriatic arthritis, and such. So I agree with you 100%. It's about boosting your immune system, which isn't even a thing. It's not a real thing. It's about optimizing your immune system, because the immune system can go haywire, as what happens in autoimmune disease, like what we just talked about. It can also go haywire in a cytokine storm. So the immune system is not to be boosted, it's to be balanced and to have enough of the things that you need and not more of the things that you don't need. So you don't need excess of certain things, you just need the certain levels, a certain range of certain things. And for vitamin D, it seems that the ideal range is around 30 ngs per ml, give or take. Again, even before COVID became a thing, scientists of all sorts of expertise, whether that's endocrinologists or what have you, have been debating about ideal vitamin D levels for years. And the debate hasn't stopped because there's no consensus on the perfect or ideal level of vitamin D. But most experts agree that it's going to be in that around 20 to 35 range, depending on who you're talking to.
I got a couple of questions on just the leronlimab. There aren't much new details from the last time we spoke to Dr. Patterson. But as of right now, leronlimab is not being considered by the FDA for a compassionate use. In order to get leronlimab, you have to get an emergency investigational new drug application through the FDA, which requires more paperwork through the hospital system. And so I know that the team at Cytodyn is working to try to get a compassionate use. I don't have any other further details on that. I do know there's quite a bit of families that have contacted me over the past several weeks wanting to get leronlimab. So most of the time, it has been an absolute nightmare trying to get some of these desperate families leronlimab. I think a lot of it is there aren't a lot of clinical trials, and people are a little bit afraid, I guess, or not sure about giving an experimental drug. But I'm very confident in what Dr. Patton has said. I've looked over his studies. There's actually another study from China that is supporting what Dr. Patterson said regarding RANTES. So I'm hoping in the next couple of weeks that once these remdesivir studies are proving to be it's not very effective, hydroxychloroquine. In fact, if you guys saw the report, France has banned it, except in a clinical trial usage. There's a lot of data now coming that there's a lot of data that is showing that hydroxychloroquine also is going to be pretty ineffective. Plus or minus the zinc component. There are obviously a lot more studies that are going on, but that's all I have to say. Leronlimab, we're definitely keep on pushing, and with Dr. Mike and I, just our social media presence and talking about it, we know we're slowly making a difference. There's a lot of people talking about it. It's just continuing to keep fighting the system, keep fighting this old way of approaching things, and trying to get others to see new, novel, and innovative ideas and experimental drugs that we think show a lot of promise.
Yeah, and a lot of people are asking about marijuana and THC and CBD. Does it help with COVID? Well, the official answer is we don't know, but probably it actually hurts you in terms of if you're smoking it, whether you're vaping it or you're smoking it. If anything, you're probably going to cause your lungs, your airways to have inflammation, which makes you more prone to getting infections, generally speaking. And in terms of, let's say you eat it as edible and you get the CBD or the THC in your system without smoking it or vaping it, would that have any effect? The real answer is we don't know, but I highly doubt that it would, because it exerts really effects in the brain with the endocannabinoid system, and that it's based on what we're seeing with infections in general, has nothing to do with reducing infections or impairing the virus from causing infection or spreading or suppressing cytokine storm. So it hasn't been studied, but if it were to be studied, I highly doubt that having any kind of THC or CBD in your system would have any effect on viruses or bacteria in general.
I also want to, I've gotten some questions, Mike, privately on my Instagram page. There's actually a Facebook group, someone on YouTube who follows us, Mike, connected me with a Facebook group. It's a group of people from all around the world that are suffering from post-COVID-19 infections. And this is something that I'm sort of investigating right now. The interesting thing is the old paradigm we've looked at is you have an infection, you have an associated cytokine storms. If you clear the virus or you test negative, then your risk of cytokine storms dramatically goes down. So patients are still in the ICU, and the doctors, the clinicians are saying, well, they're out of not having a cytokine storm, and they're looking at some of the cytokine numbers coming down, and also saying the virus is we have a negative test. what's interesting is there is a growing number of people all around the world, in the United States, UK especially, and that's who are in this Facebook group I've been talking with, that are having a lot of, looks like sort of an autoimmune picture. Some are having lupus-like rashes, arthritis, and new onset cardiomyopathies, decrease in ejection fractions, atrial fibrillation, a lot of them with respiratory infections and respiratory complications. So one of the things I recently asked, maybe about 2 days ago, I asked Dr. Patterson about was, is it possible that these post-COVID-19 infection sequelae and symptoms are due to elevated cytokines? And it was very interesting because during our live chat, Dr. Patterson mentioned that cytokines can be elevated up to 28 days. And yesterday I shot him an email and I said, could it be elevated longer? Could we talk about weeks and months? And he goes, absolutely. So it's, you know, I think in the coming weeks and months, we're going to start to see more, as more of these patients have recovered from COVID-19, we're going to start to see the post-infection complications. And I feel like cytokines are going to play a pretty integral role in the pathogenesis. And maybe we should be looking, and maybe we should be testing these patients when they're discharged from the hospital. We should be testing for some of the cytokines like RANTES, MCP1, IL-6, and just can't assume they have a negative viral test. That means that equates to a negative risk for cytokine storms. I don't know if you've sort of seen that, Mike, in sort of a readmission or patients in your ICU with COVID-19 that got readmitted a day or two later. Have you seen that?
Haven't seen it in my hospital and my intensive care unit, but I do have a patient who was in the intensive care unit who didn't require intubation, and he ultimately he was requiring lots of oxygen and just short of intubation. He ultimately improved. He got better, but to this day he's still requiring supplemental oxygen at home. So he has nasal cannula supplemental oxygen that he uses at night, which is a lot less oxygen than he was requiring before. But still, he first got infected over 2 months ago. It's probably 3 months ago now. And he's had a very, very slow recovery, and he's still not anywhere near back to his baseline. And when you look at his CAT scan of his lungs, you see the typical very intense inflammation that you see with COVID. And he's actually had a complication that's pretty uncommon, but he's had a pneumocyst, which is basically sort of a hole that forms within the lungs. It's not really a hole within the lungs, but it's a hole that forms in between the lobes of the lung. And pretty good sized hole there. And that's actually not directly why he's still feeling ill, just because of all the residual inflammation that's spread throughout both lungs. So, he's slowly getting better, but still it's 3 months out and he's still not back to 100%. So did he get readmitted to the hospital? No. There was another patient who I swear up and down had COVID, who tested negative, I think 3 different times, but we all know how inaccurate these tests are. I swear up and down she had COVID, and she did get readmitted at one time back to the hospital. You look at her CAT scan, and it's typical of COVID-19, and she required lots of oxygen. She ultimately had a bronchoscopy done, where we go down inside the lungs and we do tests where we actually did a biopsy of the lung, bronchoscopy. And we tested her for everything under the sun, and everything has come back negative. So was it COVID? We're not 100% sure, but based on the inaccuracy of the test, I'd be surprised if she didn't have COVID. Anyway, she ultimately got better. Again, took a long time over the course of several months. But yeah, she was one of the people who I think had COVID who did get readmitted to the hospital. So she never required intubation, thankfully. But we're seeing lots of variations of the disease. I know I did a video that talked about how It affects all the organs and everything. But in terms of, what it causes in people, some people it's no symptoms, some people it's mild symptoms, some people it's to the point where they need to be in the hospital, but they don't necessarily need the ICU. Some people need to be in the ICU, but don't necessarily need to be intubated. Some people need to be intubated. Some people require ECMO. Some people ultimately die. So it can go one of many ways, and it's very, very strange. There's other diseases that sometimes go that many ways, but I don't think to this degree.
And I think just to follow up on an interesting point you brought, I think early on in the when COVID-19 came into even the UK, in the US, they were not testing people as much, just didn't have the test kits, or for whatever reason. So I think you had a good chunk of the population that got exposed and infected, cleared the infection, but obviously never got a test because it was not available. So you got that subset of the population to consider. That when I'm speaking to people in this Facebook group, I probably talked about 30 to 35 people the past week. I'm just getting emails and text messages now. It's really interesting how it's almost a 70-30 split between the people that have had COVID, about 70% say yes, we had it, and there's about another 30% that say we had symptoms. And you can't discount it. You can't say, well, they're making this up, because we really don't know. And they're suffering from some really bad complications. You obviously see patients in a clinic, which I don't, being an anesthesiologist. Are you seeing more, or at least, speaking with some of your other docs, are they seeing more cases of these pulmonary fibrosis or complications from the infection, or is it too early, you think, to be seeing that yet?
Well, to answer the first part, no, I haven't seen any fibrosis. I've seen, whether it's a pneumonia from a different cause of infection, whether it's bacteria or viruses. When you have a pneumonia that you can see on the X-ray or the CAT scan, typically the patient gets a lot better before the X-ray does or the CAT scan does. So someone could be totally fine, and what you see on that chest X-ray or that CAT scan, it takes a long time for the body to make the changes to make that disappear. So with COVID and COVID pneumonia, it's going to take a while for those changes to disappear on the chest X-ray and on the CAT scan. Usually, when you're going to see fibrosis, it takes a while for that to show up on the chest X-ray or the CAT scan. So typically, that's after months to years of development. So it's probably too early to start seeing significant degree of fibrosis, especially on a chest X-ray. You're going to see it faster. You're going to see it sooner on a CT scan. So most people who have COVID aren't getting CT scans, and if they do, most of them aren't getting another CAT scan after their initial CAT scan, especially like 3 months after, or even 2 months or 3 months after their infection. So the answer is we don't really know for sure. There might be some cases here and there, but it's not like there's been a big study that's showing, okay, here's the CAT scan of when they had COVID pneumonia, and then here's the CAT scan of them 3 months later. Let's compare A to B and see if they now have fibrosis. So don't really know at this point. It's not something that I've been seeing. I haven't been seeing fibrosis. I don't know if my colleagues in other hospitals are or not, but I haven't heard of that happening.
Mike, I got a question about, what about established drugs with known safety profiles that happen to increase interferons and reduce things like interleukin-6 being used off-label? They could be of use before leronlimab is available. And this is I'll sort of give you my take, and I'd like to actually hear what you have to say about this, Mike. I think this off-label use, hydroxychloroquine is the first thing that comes to mind. And really, any medication we're going to be using for COVID-19 is going to be off-label. We're in the middle of a pandemic. We're not going to get those RCTs and all those phase 3 trials and approvals and whatnot. Even no matter how much we want to fast track it, it's going to take a while. So if you look at some of the drugs that we are already giving, hydroxychloroquine being one of them, I would probably even say remdesivir. I don't think it's been approved for. Correct me if I'm wrong, Mike. I don't think remdesivir has ever been approved for really any medication. It was used to initially study Ebola and the first SARS and MERS. And then tocilizumab is another drug that we use for rheumatoid arthritis, which is sort of being used as an off-label use. So it's much easier. The problem is, anytime you're using off-label medications, which we use a lot. I mean, being in anesthesia, I use a lot of off-label devices and medications. When I say devices, usually like, for example, ChloraPrep is actually an off-label use as a disinfectant for spinals and epidurals. But you have to weigh in the medical legal things. I mean, that is the reality. You have to feel like you've exhausted all your options, possibly talking to risk management at the hospital, talking to hospital administration. So it's not easy saying, okay, a drug is FDA approved. Just because it's approved for one condition, we can just hand it out without really investigating and looking at it a little bit more closely. So it's a little bit more, even though if it's off-label, it definitely makes it easier obtaining it and using it, but there are definitely things to consider and more hoops to jump through. Mike, what are your thoughts on that?
Yeah, it's more hoops, and you're right. I mean, it's not like we can just invent a drug, or scientists can just invent a drug specifically for COVID and have it ready tomorrow. They can invent a drug for COVID, but it's going to take a while to do the studies in animals, and then see if it works in animals, and then see if it works in people after that. I mean, it's going to take a while before that happens. So you're right. What we need to do is repurpose the drugs that might work for COVID, such as what you mentioned, tocilizumab, which is an IL-6 inhibitor. There's another IL-6 inhibitor, sarilumab. IL-6 really does seem to be central in the cytokine storm, and inhibiting that makes sense. It makes sense that it's an IL-6 inhibitor, and when you stop the IL-6, you're going to stop or slow down the cytokine storm. Part of what makes it hard is, okay, you have to run the numbers of people and see if it works. Looks like it's happening. Looks like people are getting benefit from it. But again, the randomized controlled trials are still pending on that. The other thing is, and this applies to all the drugs, is at what point do you give someone the drug? And again, this is just another reason why COVID is such a weird disease, because like I was mentioning earlier, some people get symptoms. There's that end of the spectrum, and then some people die, and then there's everything in between. And then people who have bad disease, they could be fine all of a sudden, and then all of a sudden they tank, where they're crashing and they need to be in an intensive care unit right away. So at what point do you give someone the IL-6 inhibitor? That's a hard question to answer. Now, if someone is slowly getting worse, then you can, start thinking about that. But it's not like everyone is going to get IL-6 inhibitor who's infected. If someone's doing okay, they don't need supplemental oxygen, you're not going to give that person IL-6. However, the person who's not doing so well, where they need more and more oxygen, where their vital signs are deteriorating, that's someone who you're going to want to consider giving tocilizumab, the IL-6 inhibitor. And then the same thing applies to things like convalescent plasma, which is also being studied. Also looks like it's having promising results, but we'll see. And the same thing applies there's already something called recombinant human ACE2 receptor. So it's a soluble IV form of ACE2. And this works in two different ways to battle the virus. One, it is the ACE2 receptor. So when you give this to someone, it gets in their bloodstream, it actually binds to the virus. And then the other aspect of it is when you're giving someone more ACE2, you're actually affecting the renin-angiotensin 2 system within the lungs, and therefore you're going to get more stimulation of that MAS receptor pathway, that MAS receptor pathway. And we already know that when you have more stimulation of that pathway and less angiotensin 2 within the lungs, what ends up happening is you get less inflammation, less fibrosis, and less clotting. So that drug is actually being studied right now, or is about to be, in randomized controlled trials. And that's something that I would be very optimistic about and can't wait to see those results. In addition to the things like you mentioned, I want to see leronlimab because that also plays a part in inhibiting the cytokine storm with RANTES, as you mentioned. So lots of different things that are being looked at, and I'm sure everyone's getting impatient, as I am, because we want results and we want results now. But these things unfortunately take time. The other thing someone was asking, because I mentioned clots too, is antiphospholipid syndrome. That's another fascinating aspect of COVID. About 30% of COVID patients who have at least moderate to severe disease end up having clots. And so while we can give someone blood thinners, can we give something else? Or what about people who have underlying clotting issues even before COVID, such as antiphospholipid syndrome? Does a baby aspirin help? Should they take it prophylactically? Should someone take a higher dose of aspirin prophylactically, like 325 milligrams? Should someone be, depending on what underlying illness or condition they have or underlying clotting disorder they have, should they be taking, should they be extending their Eliquis or extending their Xarelto or warfarin or Coumadin? So these are all questions that we don't know the answers to at this point. Just really, everything's so new, and this disease is only 4 or 5 months old. So a lot of questions that we're still trying to answer at this point.
Mike, can you repeat the name of the ACE2 drug? I'm not gonna burst a bubble. You can sort of tell. I think someone just had a question about that. I know how much you love that drug. So go ahead.
Well, I love it because it makes so much sense from a pathogenetic standpoint. The pathophysiology of this disease, and then this drug actually works it's like a double hit with this drug in slowing down that pathophysiology. Again, we don't know for sure because the randomized controlled trials haven't been done. But it's called recombinant human ACE2. So RH, it's actually lowercase r, lowercase h, then capital ACE, and then the number 2.
Mike, there's a question I got was, maybe you might also know a little bit more about this. If there was if group Streptococcus F is related to COVID-19. So I haven't seen really any correlation between any of the streptococcal infections, including the group F Streptococcus. I will say, and COVID-19. I will say that it's very interesting because Dr. Patterson has been able to illustrate, along with other researchers, that there is immune exhaustion in COVID-19, as evident by a decrease in CD4 CD8 ratios. And I suspect that if you're seeing some correlation, then you are seeing a quote-unquote weakened immune system because of the immune exhaustion from COVID-19 that makes you susceptible to some of these bacterial infections. I haven't seen any studies looking at the correlation, so I'll actually ask Dr. Mike if he has seen any correlation between group F Streptococcus and COVID-19.
No, not anecdotally or in any of the scientific published papers. I haven't seen any correlation.
And there's I'll throw this question at you, Mike, from Gora. He says, how is Remdesivir the standard of care? Or I guess the question is, I guess I'll rephrase what he said. Why is Remdesivir the standard of care?
It's a tough question to answer because the studies are hard to interpret, and that's for a number of reasons. The studies that are being done on COVID patients in general, it's really hard to study because there's so many different factors that go into it, and we haven't even defined this disease very well. There's different aspects of the disease, there's different severity of illness, and also because of the pandemic, it's like the kitchen sink is being thrown at these patients with different drugs at the same time, and that's only complicating matters, and you're adding so many different variables on top of the drug that you're looking at. So in a perfect world, which is ethically impossible to do, but in a perfect situation, what the way that you'd want to study is have a double-blinded randomized controlled trial where all the patients who have a predefined severity of illness of COVID, you split them up, you give one remdesivir and you give the other placebo, and they're all at a certain point of time in that infection. That's how I want to study that, of course, with millions of numbers. But part of the problem too is we don't know exactly what stage of illness these people are in when they're getting the drug. So we know that typically the virus, people get symptoms within about day 5 on average. So again, if someone were to get remdesivir on day 0, that would make sense that they're going to fare better than someone who's getting remdesivir on day 5 or day 14 or day 21 of their illness. So at what point in time of their illness are they actually getting the drug? So that's going to have a big impact. And in all these studies, there's no way to know at what point of time in their illness did they actually get the drug, because it's impossible to know. If you think getting a positive test result is hard, imagine trying to figure out at what point did the virus actually start infecting them, because that's impossible to do.
Yeah, and I'll also add one more thing, Mike, about what you said about remdesivir, which are all really great points. 100% agree with you. Exclusion criteria for remdesivir, it's, if you look at the NIH website, is that it has, I believe, kidney and liver elevated enzymes, which are a sign of liver damage, AST, ALT elevation, and looking at the creatinine clearance. So obviously a sign of kidney damage, which you're seeing in severe COVID-19 patients. So we have a drug that has been approved as a compassionate use in remdesivir. But the ironic thing about this is we can't give this to so many of our patients because they are in renal and liver failure because of COVID-19. And same thing with tocilizumab. Tocilizumab has their exclusion criteria is on the NIH website is the AST, ALT elevation greater than 5 times normal, or the upper limit of normal. I didn't really see anything about the kidney on the clinical trials, but there's a suggestion that I've read that maybe there might be some kidney exclusion and a kidney exclusion criteria. So again, we've got another drug that's been approved, or it's actually an off-label use, so it's much easier to obtain. And we can't give this to these patients. So at the same time, we have leronlimab, which again, I'll also say this again. I have to say this every time I talk about leronlimab. Dr. Mike and I, we're not paid by this company. We are, we wish, then we wouldn't be in so much of debt paying our med school loans off. But it just shows a lot of promise. And where there's smoke, there's fire. And when you listen to the doctor in Montefiore, Sitam Haredi, can't pronounce his name. Apologize for butchering his name, and Dr. Otto Yang, they're both saying, look, we don't have the studies, we don't have the information, but anecdotally, there's something there, and we need to investigate. So it is definitely a puzzle why remdesivir has been approved. I'm sure there's a lot of financial and political things going on, which is not something that we want to discuss, but that is the reality of any drug in any situation we're dealing with.
Yeah, someone was asking, are autopsies always performed on COVID patients who succumb? And the answer is no. Actually, it's pretty uncommon, but just doing autopsies in general is very uncommon. But it's even more so because doing the autopsy carries risks to the medical examiner because they can get the virus too just by doing that autopsy. So they have to take the same precautions as if a patient were alive with COVID. So it's very risky to do. And with that said, it is nice when we see the results of those autopsies because we gain incredibly valuable information based on that. That's how we learn about the disease, or at least learn more about it, and it really provides a lot of insight that we can't get otherwise. And I know my last video I was talking about the autopsy results of 12 patients, and it was incredibly valuable to learn that the reason why they died, of course, was because of the virus, but it was actually from the inflammation and clotting that was occurring within their lungs. So even though we know that the ACE2 receptor is located in lots of different organs, such as the brain, testes, kidneys, heart, the reason why those patients in that study died was because of all the inflammation within lungs, or because they had very large clots, very large pulmonary emboli in their lungs. So again, incredibly valuable information.
Mike, I know we've talked about this before in another video. Since you're the lung doctor, I'm going to punt this question to you. Are there any lung surfactants strong enough to put a dent in the lipid envelope of the virus? I think this person's talking maybe about exogenous.
Yeah, it's a great question. It's a great question because they actually looked at giving surfactant to ARDS patients before COVID. And because in theory, you would think that more surfactant would make the lungs even more compliant and help with their ARDS. It's sort of a similar process when you give it to infants who are premature. You give the surfactant and it makes their lungs more compliant. Well, when they looked at it for ARDS before COVID, the surfactant actually didn't improve their outcomes. So that's why surfactant is no longer given for ARDS. Now, it hasn't been studied for COVID. So would it help for COVID ARDS? There's a possibility. I don't know that there's going to be enough demand to do those studies. Again, there's lots of COVID patients, but you sort of have to be selective in what you do for studies, and you have to go with the things that you think are most likely to have an impact when you're designing a study.
Do you have any more questions?
Are hospitals ready for the second wave since areas are now being reopened or opening too soon?
You want me to answer that first?
Yeah, you're up, buddy.
Oh God, it's a really tough question. Is there going to be a second wave? I personally think yes, but I don't know how severe or it's going to be. The one thing I've come to realize is some of these projections that we had talked about initially seem to be completely off, and it's justified how people are thinking. Well, you come out and they say, "Well, I read this study," or some experts are saying that it's going to be a severe second wave. I think it's justified when people are skeptical of it because the numbers we've gotten have been totally off. In New York, we said we needed 30,000 ventilators and didn't even need anything close to that. So it's understandable. It's really hard to say what those numbers are. That's just the reality of it. And I'm not even going to try to speculate. I think our healthcare system, our hospitals are much more prepared. I think early on when the infection came to the United States, and I apologize for all of viewers that watch from the other parts of the world, living in the United States, we take a very American perspective, and I want to apologize just up front because I'm guilty of doing that. But from when I think for a lot of us, we didn't take this infection very serious. I know personally I didn't, because I had a friend of mine who I went to medical school. Actually, he knows Mike too. A friend, Christopher, went to Shanghai, came back 3 weeks later in December. He went there for a job. He came back and he said, "Ram, this is bad." And I laughed at him. He goes, "Our friends are going to die. People we went to medical school with are going to die. And people we trained with are going to die." And I laughed at him. I said, "That's ridiculous. That virus is out in Asia, and most of them have been contained. It's not an issue." And when it came to Europe, it was one of those, oh, bleep, you're right. And unfortunately, he was right. I've lost colleagues of mine and friends of mine to this infection. I think the second wave, we're going to be much more prepared. I think we're not going to be scrambling to decide what medication is hydroxychloroquine, is remdesivir, what are we going to do? I think we're going to have a better handle. We're going to be able to tell. There's going to be that great unknown is gone. And as Dr. Fauci has stated, and many other health experts, we're going to be prepared the second time. The question is, how severe is it going to be, and is it going to overwhelm the healthcare system? And that's something I don't know, and I'm not even going to bother to speculate. Mike, what are your thoughts?
Yeah, I think that this country will be much more prepared for the second wave because we've seen what happened the first time around, and there's obviously lots of time in between the first wave and whenever the second wave hopefully doesn't happen, but I think it's probably going to happen. This second wave, that's probably going to happen. So the companies have had time, the hospitals have had time, and we know more about this disease than we did before. So if and when the second wave occurs, I think we'll be much more prepared. It's still not like, oh yeah, we're fine, no problem, we got this. It's not like that. But it'll be better for everyone in terms of dealing with it and just overall. Hopefully it doesn't come. When it does, or if it does, we'll be better prepared in my opinion, but we'll see. And then there's the third wave that could happen as well. That's what really scares me more, actually, the second wave, because if the second wave happens soon when we're reopening, and then things seem like they're okay or whatever, or not that bad, and then here comes the winter again, coinciding with flu season. Now you have flu and COVID and other respiratory viruses. Now it's going to make things all the more complicated, and that could just be, the same thing that we're seeing as the first wave. So I just hope that this country as a whole does everything that we can to minimize and prevent COVID happening in the future. And hopefully by that time we have drugs that work, or at least show lots of effectiveness against the virus. In terms of vaccination, if we get a vaccine that works, realistically, it's not going to be ready for, 12 months at the earliest?
If it even works.
If it works. And, listen, we haven't cured HIV, right? But look at, people who get HIV medications, they have the same life expectancy as people without HIV. So while there isn't a cure, look how the science advanced so much to, where HIV started with the AIDS pandemic and to where it is today. Again, that was many years, but you could see how the science can do amazing things. Just like when we eradicated smallpox back in 1980. Horrible disease. Eradicated. So I wouldn't doubt the science. I wouldn't doubt the capability of the science with, the vaccinations. I know people are very doubtful of a new vaccination for COVID, but when you look at what we are capable of, I wouldn't be surprised if we get an effective vaccination, and I certainly hope we do, and hopefully it's sooner rather than later. But we'll see what happens.
And I think you made a great point, Mike, about the medications. I'm hoping that leronlimab is given, and some of the other experimental drugs are given a more closer look, so that a lot of these questions that we really don't know, no one can conclusively say that leronlimab or any of these other experimental medications do work. I don't think anyone can say that, and I don't think you and I are even saying that. But you got to give these drugs a chance. You got to test them out. If we don't test them out, we don't know, and it's just all mere speculation. So I'm hoping when there is a second wave, we have a better understanding about leronlimab. So maybe maybe a couple months from now we say, you know what, this didn't work. The studies show it's not as effective as we wanted, just like remdesivir or hydroxychloroquine. Or maybe the studies say, hey, this is it, like a lot of us have been expecting and hoping. So we need those studies. There's a question that someone asked Mike about some companies are developing compounds that may help but are not yet involved. Would you be willing to reach out to these companies as doctors to encourage them to try these compounds? And I guess, the other thing I would also add to that too, and Mike, I want to get your take on it, is if there are experimental drugs and things that are showing promise, what are your thoughts on that? If I come to you and I say, Mike, there's you got a patient that is got about, let's say, 4 or 5 days to live. They're they're an intubated ARDS, liver failure, whatnot, and the family comes to you and they says, Dr. Hansen, there's this experimental drug. It's on a phase 1 trial, maybe a phase 2 trial. Anecdotally, is showing some promise. Families are 100% on board. As a clinician, that patient has maybe about 3 or 4 days to live. Would you give that medication?
If I think there's a chance that it could work.
But even if you didn't think it would work, they're really bad. Their PEEP is like 22, FiO2 is 100, their PaO2 is 60. They're in the worst shape. Let's say like in the next 72 hours, there's a 90-some% chance they're going to expire. You've exhausted everything. You've given everything, tried treatment, proning, ECMO, everything in your handbook. And a family comes to you and says, Dr. Hansen, in 24 hours, we could get this drug. It may work. It may not work. Would you give it? Would you at least strongly consider it?
Well, I'd strongly consider it if I thought it had a chance. But
if it didn't,
let's say the family's like, we read somewhere that arsenic can cure this. Does that mean I'm going to give the patient arsenic? No. So you have to make a clinical decision. Is it at least worth trying, in your opinion, based on your medical expertise? And you could always look things up and see and make a decision. Is it medically reasonable to at least try it? And if you can answer that as a yes, then you could say, well, it's worth a shot. But otherwise, no, you can't just give a patient anything if you don't think it's clinically justified.
And I asked my dad this very question. My dad's critical care, I don't know, feels like the beginning of time, almost 40 years. One of the smartest people I've ever met. And I asked this very question. And really, I know it was the way I phrased it to you, Mike, was maybe a little bit, I was a little bit vague. I'm really looking at, let's say, a drug like leronlimab. And I hate to keep on beating this thing. And it's not really, I don't want to focus so much on leronlimab, but I'm going to use it as an example when I talk about experimental drugs. Because I feel like there is a growing number of families that are really frustrated that some of these experimental drugs, and I'm not saying only leronlimab, but some of the other drugs, are not even being considered. And obviously, like you said, it's really tough. You have to take like the clinical viewpoint. You have to look at the clinical picture and see if it's actually really going to help. But if you've got a drug that doesn't really have a lot of really serious adverse events, what harm is there? If it works, it works. If it doesn't, what do you have to lose? And it's funny, I asked my dad that same question, and he, he kind of said, well, I would then consider it as long as the family was on board. I spoke to the risk management, I spoke to infectious disease, and the hospital administration was all on board. Then I would consider it. And that's after all the conservative management or the standard of care therapies were exhausted. So it's just an interesting question, something I've been contemplating, and I just got a couple of questions on that from some of the people on my channel right now. We're just talking about some of these sort of novel drugs, and one of the questions one of the discussions I've been having with other physicians is, and a lot of other people for the matter, is why aren't we giving a closer look at these medications? If I know someone's going to die in 3 days, yeah, exactly, I wouldn't give them like arsenic or give them something like a known, or like a something that would cause clinically is going to cause some problems. It's just starting to really make me upset that.
Well, again, if you're in that situation and you think, again, the family signs off on it and you think there's a potential, and there's clinical reason to think that there's a potential, not just because you're, a snake oil salesman, if you think there's reasonable potential based on some kind of evidence and the family agrees to it, then yeah, sure. But again, you have to have some kind of clinical justification to give someone something. And so you could make the argument, especially during a pandemic, that this drug has some clinical evidence that it may work, and don't know yet, but the family agrees to try it regardless. In that case, it would be worth at least considering giving.
Put it this way, Mike, if I get COVID-19, I'm going to make sure I give you a call and come near you. And if I get really sick, I'm going to make sure you take care of me, and that you're going to give me leronlimab. Make sure you go very gentle with the intubation. I don't want you to break my teeth, because I do expect to wake up and walk out of that hospital after my infection.
Well, I was going to give you a morphine drip and play Pumping Iron on repeat, but...
I don't think our audience knows about our Pumping Iron story. We'll have to tell that to them one day once the pandemic is over.
Yeah, but in all seriousness, I mean, based on what I know and speaking with Dr. Patterson, if you were in that situation, yeah, I would be all for it, especially because the hard part is justifying it without any kind of trial. But in terms of if I could give that in a hospital and I was given the green light to give that to you, I would be all for giving you that drug, absolutely. In that situation,
and
like I said.
Exactly. And I wasn't, I know my question was a little bit vague, and I know we're getting another question, but I feel like this is sort of important, Mike, a really important question, because this is something that we're really facing. I know you're getting some questions about it. I'm inundated with text messages, and I didn't realize my cell phone number is on my website. So there you go. Now, I've had people call me, but where'd you get my number? Oh, it's on your website for ECA Wellness. I'm like, oh my God, like I have to get that changed. So you guys should rush and get my number. It's all out there in the open. But going back to this discussion, Mike, it's just interesting how, you're very open-minded. You're willing, and I've known you for 17 years. You're such an advocate for patients, and you would do whatever it takes. It's just really disheartening for me when I have families and people calling me about their loved ones, and they're saying, the hospital, the doctors don't want to do anything. They don't want to try. They're not even looking. They said no, blanket statement, no experimental drugs. And a week later, these people are dying. A couple of days later, I get a text message or an email or a call. My mom died. My dad died. I don't know. It's really hard. And I understand from the clinician's point of view, where we want to be cautious. I'm probably one of the most conservative physicians. I mean, I'm so stingy with my medications when I put someone to sleep.
Well, it's always like the oath that we took: first, do no harm, right?
Right, but do nothing, I think, is I'm starting to realize do nothing is worse than do no harm. And we're so ingrained in this do no harm culture that we sometimes turn a blind eye to things that could potentially work. And I'm not saying,
well, that's the thing is we don't. It's always a lot of it is a gray area because it's always a balance of do no harm versus do something. And the reality is that you don't know where that line is in between the two, and it's a gray area.
Right.
And a lot of people, that's what our profession is about. That's what science and medicine is about, is figuring that out exactly. And that's what the studies do, at least the good studies, and the trials. And it's unfortunately these situations during a pandemic, it's a horrible situation to be in. It's a horrible situation to be in a pandemic, and it's a horrible situation to be in that situation where you don't know the drugs that you're giving, how effective they are, the side effects, what are those, and are you doing more harm than good? That's what the studies are for. So giving someone leronlimab at this point is a gamble, which of course I would take that gamble if I could, or if I was the patient, I'd say, yeah, I'll take that gamble. But that's based on our, intuition, on medical knowledge, and reading all these papers and reading the science. We don't have proof that leronlimab will work, but based on what we understand of the disease and the science and the preliminary reports, it seems like it makes sense that it will help. And so that's why if I were in that situation, I'd say, yeah, I'll take it. I'll take that chance. Now, of course, there's other things that I'd be willing to say yes to as well, just like tocilizumab or convalescent plasma. These are things that I'd be willing to receive because I think it's likely they would help me in that situation. Of course, those things that I just mentioned are being studied in randomized controlled trials, but those trials haven't been published yet, and we don't know for sure at this point.
Yeah, no, absolutely. And you bring up a very good point about, as clinicians, the gray area, like you stated. I mean, there are no absolute truths in medicine, even with the randomized control studies and the trials and stuff. I mean, we're getting new data, we're understanding things, and I think that's one of the biggest challenges, at least for me. Yeah, I think I'm more of the what do you have to lose clinician. And if someone wants to be conservative, that's fine. Like I said, I'm conservative in some ways with my management, but with this pandemic, I start to think about my friends and family and what I would do. And when people contact me, I get pretty emotional because I start thinking about my parents and I start thinking about my friends and my loved ones. And I would, we're blessed, Mike, that we went to medical school, residency, fellowship, board certified, all the years of training, that we understand the system. We understand not just the medicine, but how the process works. And there are millions of people, not only in this country, but just around the world, billions of people for that matter, that don't really understand and know what we know. And I guess maybe for me, it's maybe I take it for granted how much I know when I talk to some of these families. I'm like, why don't you just do this? And then it's like, wait, know about that. And it's, it can be very humbling. It's been a very humbling process doing these YouTube channels, these live discussions and these videos and interacting with people and stepping outside of my comfort zone and talking to people I never would have otherwise.
Yep. And I'm glad that people are showing up and asking questions and want to learn. And when they want to learn, it motivates you to keep going and to keep teaching and telling, spreading the knowledge that you do know and being honest about what we do and what we don't know, especially because things are so new with the virus. And there's studies that are being done that scientists and doctors just don't know yet. And it's easy to say take garlic and it's going to cure you or prevent you from COVID. It's easy to say that, right? It's easy to go ahead and video on that, right? But it's hard to actually really research things, put things together, and put out the most accurate information possible. That's it takes work to do that, but it really does motivate me when I see people who are truly appreciative of what you're doing. So, hey, to everyone who's watching still, I know we're going pretty deep here, but I want to say thank you for showing up. Thank you for watching. Thank you for commenting, whether that's on YouTube or Instagram. I appreciate that. It definitely motivates me to keep going and battle the misinformation that's out there. And hopefully, of course, the end result is to get people healthier, to get people through this, not just with COVID, but also other health issues, and, live a healthier life and live longer. And, that's really what it's all about. So, I'm glad to be doing this. And I know you are too, Dr. Young.
Yeah, no, it's just crazy how, Dr. Mike and I have been doing YouTube, videos for months before COVID-19 even came into the picture. We never really thought that we would be doing live videos or live Q&As and getting guest speakers and doing this. I don't think, it was about a year ago that you and I were talking about, hey, maybe we should just start making YouTube videos. And I was opening up a wellness center and talking about fitness and health. And you were, we were kind of brainstorming how we would do this. It's absolutely humbling. Despite being a physician, it's absolutely humbling how much I've learned from the YouTube community and social media. Sometimes you guys listen to us and, we are giving you information, but it's a two-way street. Some of you have shared studies, told you about medications, treatments. Some of you have shared your personal stories and your tragedies, and it's absolutely humbling. Yeah, sometimes I get pretty emotional too, so which I think I'm probably about to. So I'll turn it over to Dr. Mike now.
Well, yeah, and it's nice to see that doctors are people too. Doctors are humans who have emotions too, and we were friends long before we were doctors. So there's that. For those of you who don't know, we actually met on a tour of our med school, St. George's University, and we met on the tour. So this is before we actually started classes. This is like probably 2 months before we started. This is, I think, December of 2003. And
no, it was before. It was in October.
October.
That was
okay.
That was that British girl, the vet student.
Megan, right?
No, Megan was the girl we met on the beach
from
Canada. But Victoria.
Victoria,
the
okay.
Student.
I can't remember. But anyway, that's when we first met. And then we're like, hey, you know what? You seem like a cool dude. And we're like, let's be roommates. So then we ended up becoming roommates for very first semester of med school. And then, I brought back then it was DVDs, right? So I brought my DVDs. Half of them were like Arnold's movies, Predator, Commando, Terminator, and of course, Pumping Iron, which I can't believe to this day that this guy actually liked Pumping Iron back then so much, to the point where people would get annoyed with us probably because we were quoting every single line from that movie because we'd watched it like 100 times over when we weren't busy. When we weren't busy studying.
First semester. So Mike Hansen. I know we're not talking about COVID. We're just getting into personal stuff of who we are. So, Mike Hansen says, "Hey, this is literally first day. I walk in, He goes, "Hey, have you seen Pumping Iron?" I go, "No, I've heard of it." And he goes, "You got to watch this." So I was hooked. I think probably 50 times we saw that first semester of med school. Like we would, before a big exam, we would watch clips of that with like 10 or 12 of our friends. And just to get super like pumped up,
It would
before an
motivate us to
exam.
work out in the gym. Like it would
Yeah.
like motivate us. Yeah.
And also make us laughing because you
Yeah.
got, I don't know if you guys have ever seen Pumping Iron. It's just a bunch of characters. And even to this day, 17, almost 18 years later, we're still quoting Pumping Iron. And all our friends, that's all we do is we sit and quote Pumping Iron all day long. We're in the hospital talking to families, patients, and someone will say something that reminds us of a quote from Pumping Iron, and they're just. So as Dr. Mike said, we're normal people. We're just regular people, just happen to go to med school, study our butts off, but a great time in med school. We, parties, basketball tournaments,
Broken noses.
also broken noses. I'm actually going. You know what? I've been tempted to post that picture of Dr. Mike's broken nose.
I should incorporate that in a video.
You should actually. That should be a thumbnail in one of your videos because. So I remember he comes back and we were playing basketball, and I remember this kid elbowed Dr. Mike in the nose, and you were bleeding on the court, but I didn't recognize you broke your nose until you came back, and I was looking at you. I said something is wrong here, and I'm like, oh, you broke your nose, man, and you were like, what? That's when Kathy made spaghetti for you that night.
Yeah, that's right. And I remember when I first broke my nose, I was bleeding so much. And I remember one of the other first term med students, of course, that means they're a doctor, right? So they're trying to help me. And they're like, put your nose and put your head back. And I just remember doing that. And all this blood is rushing, gushing down into my throat, my gurgling on my blood. I'm like, no, I'm not doing that. It's not good. Anyway, I remember I put ice on my nose, and then I like class the next day, went to lecture, and people were coming up to me and like, man, your nose isn't that bad. Oh,
I remember that. That was great.
But
well, here's the other interesting thing. Dr. Mike is actually a pretty good drummer. So we, when we were up in New York, third year of med school, I started up. I played guitar and piano and all this other instruments, and Mike plays drums. And I was putting this band together, and I was like, "Hey, can you like fill in for us until we got a permanent drummer?" So Mike actually played our first couple of shows. We toured all around New York City. In the day, we would be med students, and at night, we were trying to be rock stars, playing in all these little dive bars on Lower East Side in Manhattan, Brooklyn, hauling our equipment around and having our surgery and pediatric rotation books in our backpacks.
Yep.
So,
and then fast forward, and then you went into anesthesia residency. I did internal medicine, followed by pulmonary and critical care, and it's amazing how long it's been. It's really time has flown by. And
yeah, I think at the end of the day, Dr. Mike and I, we're approachable. I think a lot of you guys have reached out to us, so continue doing that. I'm very grateful for the questions. I don't have all the answers, and a lot of times, if you see my comments to you, I can tell you that I don't know. I'll have to look it up. I'll have to talk to either Dr. Mike or someone else. And that's the thing about medicine. It's humbling. I grew up around doctors. My dad's a physician. My sister's a physician. It's a humbling profession. And as Mike's talked about it, we talked a little bit about how the human body is so complex, and you're not going to know everything. And even when you do know, you think you know something, you're going to be humbled very quickly. So I'm very grateful for the questions. Please continue sending the text messages, phone calls. I do answer phone calls. I don't know why, but I do because I feel bad.
Type your Instagram in the comments section. It's ECA Wellness, right?
ECA Wellness, and then my YouTube channel is Dr. Yo. ECA Wellness is my wellness center. It's a performance sports center, which in the next couple of weeks, I'm hoping to start making some videos on workouts, home workouts, all of that kind of a science and medical based stuff. Interesting enough, Dr. Mike and I both have a background in exercise physiology. We come from two different worlds, but it's so funny how many things we have in common. So, yeah. Did someone ask? Did I want to cover? Did I want to cover? I want to be sedated. No. We Dr. Mike played in a rock band, a classic rock band. I think there was a time in medical school where he was not sure about going into residency and wanted to be the sort of playing a Guns N' Roses like band with our friend Lefty.
Well, I'll tell you, the two times I had the most fun in my life were actually down in Grenada in med school during the first 2 years, just hanging with people, meeting new friends, going to the beach, going to the parties. Those are some of the best times of my life. And that was rivaled by my time in New York during clinical rotations where I was, playing different gigs in New York City with my band called Wet Coma.
Oh my God! And wait, Mike, is your tattoo accessible right now?
It's still here. It's still here. Wet Coma.
Oh my God!
There's actually more of a design. I didn't get the rest of the design, but anyway, got that in 2000, either 2006 or 2007. I got that. My mom didn't think it was real, so she put olive oil on a napkin and she tried rubbing it off. She didn't think it was real. But.
No, I didn't get a tattoo with my band name on it, but what did I play? I played. I'm a classically trained pianist. Played guitar and bass. Dr. Mike, drums and guitar?
No, just drums.
Just drums. Yeah. He's a fantastic drummer.
That's the only lie you've said tonight, but it's okay.
It's not true. I'll try to get Dr. Mike to make a video on. Maybe we'll do like a music video once the COVID pandemic is over and everyone's a little bit more relaxed and we can joke around a bit.
Yeah.
We'll do like a video on a music video.
Yep. Meanwhile, if you guys have questions or lots of requests for a topic for a video, let us know. So Instagram, I typed it in. I'll do it again. So it's Dr.Hansen spelled out. That's my Instagram. And then Dr. Yo's is ECA Wellness.
Yep. And Dr. Hansen is Dr. Hansen, right? Dr.
Yeah.
Hansen.
DOCTOR.HANSEN. So guys, stay well. Do the things that you already know to do, like exercising, eating healthy, getting good sleep, avoiding stress, maybe a little 1000 of vitamin D. And then everything else that you already know about with the social distancing and washing your hands and all that good stuff and masks. So stay well, everyone. And Dr. Yo, you have any final thoughts?
Nope. I think I've yapped enough about leronlimab and our days in med school. So until the next live session, and like I said, keep the questions, keep the comments coming, it's fantastic, absolutely humbling, loving it. Thank you.
Thanks everyone. Have a great night and stay well. Take care now.
All right. Good night.